Well, welcome back. We're going to continue this discussion on chronic obstructive pulmonary disease. And just to recap what we've been talking about in the first half of the show, the severity of COPD as it affects millions of people and costs us billions of dollars in healthcare. And what we also talked about was a little bit of the cause and effect of COPD and the fact that mucus plugging or the irritation of our airways due to smoking, or if you have one of these rare genetic conditions which causes emphysema, alpha antitrypsin, which is a really rare thing, but some people need to be tested for it, especially if you have a family history of emphysema for no apparent reason. There is an alpha-1 antitrypsin deficiency, which is really a simple blood test, and you could ask your physician to have that test done, and there's actually a really portable test out for that. But again, that is a rare but identifiable cause and certainly treatable cause for chronic obstructive pulmonary disease. Clearly, the most common cause of chronic obstructive pulmonary disease is smoking, and that's something that we all want to try and eliminate if possible. Okay, back to the slides. We talked a little bit about the airway and talked a little bit about that flow curve, and I have listed some conditions associated with, or at least the measurements, and hopefully you'll be able to see that. The first level shows a 70-80%, which is mild obstruction, and what that means is you're only able to clear 80% of the volume of your lung in the first second. You should be able to clear greater than that. And as the obstruction worsens, the amount of air that you're able to clear in the first second of a forced expiratory volume goes down to where, when you're in the 60 to 90%, it's 60 to 69% is moderate, 50 to 59 is moderately severe. Severe is 35 to 49, and when you're less than 35%, you're very severe. That would be hospice appropriate criteria, and you're usually on oxygen most of the time when you're in 35 to 40% range. So you want to try and prevent that from happening. This was a slide that I'm hoping that you can see. This explains what Vern had asked me earlier about what happens to the lung over time. You can see we gradually increase our lung volume up to really what is about an age of 36, actually 26. We reach our maximal lung volume at age 26, and it could be different. If you were to have asthma that wasn't treated, or if you were to have another lung or an insult to your lung at an earlier age, you may not develop the full volume of your lungs. Over time, that lung volume decreases on a linear level. If you live long enough, we will all develop lung disease, but usually something gets us before that happens. If you smoke, if you were 26 and decided to pick up smoking at age 35, then your lung decelerates, or you lose lung tissue at a very faster rate. If you decide to stop smoking when you're 45, well, guess what? You have this volume of lung you lost, and you will never get that back. Once your lung heals, you will actually start losing lung volume at the same rate you would if you had never been smoking. Unfortunately, you will reach a lower volume quicker than if you had not been smoking. So I hope that kind of explains what happens when you do quit smoking and try and get better. Now, again, exercise was mentioned. If you exercise, you still have the same lung volume, but you use it more efficiently. And by using that lung volume more efficiently, you mitigate the effects of COPD on your lung. The treatment really is to reduce mortality. Mortality is basically death. Morbidity is the term used with hospitalizations and other associated issues. And again, the one I've talked about is the number one thing you can do is stop smoking, and that's probably the big thing. Why is supplemental oxygen so important in the treatment of COPD? Again, low oxygen saturations cause the small side of their heart and lung circulation, the circulation between the heart and the lung, to tighten up, and that's called pulmonary hypertension. That's the body's natural response to having low oxygen. And one of the things I do in my office is I usually like to test people for saturations at night. It's called an overnight pulse oximetry. I pick up a lot of desaturations in the evening as people sleep. Some of it's due to obesity, some of it's due to sleeping, some of it's due to sleeping medications, some of it's due to pain medications, and they decrease their saturation. So not only are they tired because of chronic pain and pain medications, but they really don't breathe very deep. And as a result of that, that can have a long-term effect on the cardiovascular system, increasing their risk for heart disease, and a long-term problem which we call cor pulmonale or pulmonary hypertension. It's not like hypertension that people are seeing in the doctor's office. That is actually very treatable with medications. Pulmonary hypertension is not. It is not a very treatable condition. And in fact, I think they've used some bronchodilators like Viagra and things of that nature to treat that condition with very limited success. So the other thing we can do is to eat well. We can try and get regular exercise. We can take vitamins in low doses to help reduce some of the oxidative stress in our body. And there are some nutritional supplements that also do help with reducing oxidative stress, and they might be helpful. But the number one thing you should do is to stop smoking if you're smoking. I believe that is the best thing you can do for yourself for all health issues. Okay, going to the next slide. Again, we talked about, let's highlight some of the treatments that we might have. We talked about oxygen, smoking, bronchodilators, and anticholinergics. This is some of the pharmacotherapies that we may use to help treat COPD, and bronchodilators such as albuterol, albuterol is probably the primary one, or Xopenex. Then we also mix those with corticosteroids to reduce inflammation. And the newer ones, if you've probably seen on TV, like Spiriva, and those particular products are what they call anticholinergics. They actually reduce some spasm in the small airway, and they reduce mucus production. That's why they're associated with dry mouth and constipation and some other bad side effects from that. Let's see, let's talk about each individual treatment. And one of the things I like to talk about is the bronchodilator. A lot of people don't really understand how to use a bronchodilator. They use the handheld ones. It really, we're probably going to go to break in a few minutes, but when I come back, I want to show you the proper way to use a handheld nebulizer. And a lot of people try and take that nebulizer, they'll shake it up, and they'll put it right at the end of their mouth, and they'll try and, take a big whiff on it and see if it'll go in there. Well, that's really ineffective. That nebulizer comes out at close to 200 miles an hour, maybe faster out of that. Most of it is hitting your mucous membranes on the back of your throat. And from that, you'll get this, people will report a slight jitteriness as they're using their bronchodilator. That's because it's being absorbed in your mucous membranes and it's not being absorbed in your lung. So the one thing that can help that is a spacer. They sell them at the pharmacy, AeroChamber, and a few of those other ones. Even your physician can write you a prescription for a spacer. And what you do is you spray it into that particular device before you inhale it. Yes, you waste it on that particular side of the object, but it's better to be wasted there than waste it on your mucous membranes and not get to your lungs. When you use an inhaler correctly, you should not feel any jitteriness at all. Sometimes we'll use a nebulizer, which is obviously, if you've ever been in a situation where you've seen that, they're actually a aerosolized thing. It actually has oxygen pumped in there, and you'll see the mist coming out. And that's something that they'll do in emergency rooms and in treatments on emergency room treatments. The next thing, we talked about the spacer. Now we're going to go into supplemental oxygen. And basically, one of the things I want to talk about with oxygen in late stages of COPD is that you can become what they call a CO2 retainer. And what that means is very late forms of the disease, you will actually have such a low oxygen concentration in your body that the carbon dioxide is actually your driver. It actually stimulates your brain to breathe. And so when you give a late phase person with COPD a lot of oxygen, you actually cause them to slow down their breathing. So I don't see that very often, but it is one of the signs of a very, very late stage of COPD. And again, the big key here is that supplemental oxygen is the only proven medicine that reduces mortality. And I think that's one of the things I see in my practice quite often is that patients say, oh, I don't want to use oxygen, I want to be addicted to oxygen. Well, you are addicted to it. You're dependent on it. And again, that defines the difference between addiction and dependency. Addiction is defined as doing something despite the negative consequences of the action. So there are no negative consequences of being on oxygen, right? Everybody breathes it. So therefore, you are dependent. I'm dependent on oxygen. Everybody who's healthy is dependent on oxygen. When you have COPD, you're really dependent on oxygen. So please do not think that using oxygen is a bad thing. A lot of people will be cosmetic. They won't want to use oxygen because they don't want to carry around a tank, or they don't want to do that. But realize that as you walk and as you exercise, your oxygen saturations go down because your lungs require more oxygen. We're going to go to break, and when we come back, I'm going to demonstrate the poor man's spacer and some more topics on chronic obstructive pulmonary disease. Thank you for tuning in.